at the Navy League show just outside Washington, D.C., and we've got with us Jay Singh of the Singh Forensic Institute. Jay, thanks very much for joining us.
Thank you so much.
Or I should say Dr. Singh.
Yes.
You know, fresh in from Switzerland. Let's talk a little bit about this most recent incident at Fort Hood. The President of the United States is down there right now for the memorial service. Folks are still trying to piece together what happened. There are folks who say that this does not look like it's a PTSD-related incident. And obviously, though, there are some people who are jumping to conclusions. You've studied this incident. What is it that we know about it, and whether there's any link between this incident and PTSD?
You know, Vago, whenever any of these incidents occur, typically what we see is everyone immediately tries to establish a diagnosis for these individuals, particularly when it comes to severely violent incidents. We've seen this very recently in Arizona. We saw this with Sandy Hook, Aurora, Colorado. The list really goes on. We've had a few very tough years here. What happens is that the initial diagnosis that was made by the media at least seemed to be PTSD, and it is true that Mr. Lopez was undergoing a formal diagnostic process, it seems, for PTSD, but what we know is that he was currently being seen and medicated for both depression and anxiety issues. When we take a look, though, at returning veterans from the Middle East, at least, the recent literature suggests that what we see is that approximately 1 in every 5 soldiers returning, regardless of whether they saw active combat or not, will receive a diagnosis of PTSD, and 1 in 4 a diagnosis of depression. So even if we did end up seeing a diagnosis of PTSD being established, this wouldn't be particularly surprising given current research evidence.
Is that because the research that we have is better? I know many examples of folks who have been deployed, but not necessarily in a combat role, but have also experienced PTSD that can be triggered by any one of a number of things. You know, whether somebody worked in a motor pool or had to clean up a battle-damaged vehicle at the end of the day, and some of these images have a tendency of sticking with them. Do we need to change our understanding of what PTSD is?
Very interestingly, some of the recent work that's being done is suggesting that different symptom groups within PTSD as a syndrome are more predictive of violence, both domestically as well as to what we call stranger incidents, stranger assaults and such. So what it seems like is that this feeling of irritability, hyper-aggressiveness, so on and so forth, is more associated with harm to the family. So this more sense of anger, whereas individuals who have more flashbacks and re-experiencing of traumatic events, this is where typically we see individuals at higher likelihood of being violent towards others. But when we take a look at the simple statistics in terms of aggressiveness of soldiers returning from the Middle East, what we see is that approximately 1 in 3 self-report having engaged in some sort of aggressive act over the past 12 months, 10% of whom also self-reported engaging in some kind of a severe violent act. So this is something that is perhaps more common than we previously thought.
Should any of this come as a surprise? Vietnam veteran era friends of mine at the start of this conflict said, look, you know, we're going to start to see a whole series of problems with these kids that are returning, or folks who are returning from combat. You're going to start seeing, you know, alcohol, substance abuse problems, family abuse, child abuse issues, and suicides. Should any of this come as a surprise?
Sure. I think that taking a look at the risk profiles of civilian populations versus military populations, what we see is that the one discriminating factor that's very different is having seen active combat. We have to keep in mind, of course, that military applications of existing instruments need to be tailored to be able to take into consideration that oftentimes individuals who are returning from combat zones have not only been trained in lethal force, but also have seen lethal force applied in practice. And what can happen oftentimes is that, particularly if you've seen or have engaged in lethal force, what happens is that you become a bit disinhibited to being aggressive oneself. It's very challenging and requires quite a bit of regulatory skills, which is something that I know that certainly when it comes to compliance with ethical standards, when it comes to the military, that's something that we care very deeply about, is making sure that not only are we focusing on the physical health of our soldiers, but also on their mental health.
This is a challenge that's going to persist with us for a long time. What are the sorts of things that we've got to do over the long term? And is there a danger that these sorts of incidents could turn what is very strong public support for the troops to something other than support that's as strong for the troops?
Sure. So we can take those one at a time. I would say I think that first, something that's very important that we do now is not simply continue our speculation about individuals and tragedies such as Mr. Lopez, but really take a look at what these mental health evaluations looked like that these soldiers underwent prior to these very tragic incidents. What we need to know specifically is what was done in this violence risk assessment process. What we know is that unstructured clinical judgments, so sitting somebody down, engaging in a basic interview, doing a file report review, but at the end of the day, not using some sort of a structured device, that really this is only accurate 1 out of every 3 cases. So that means that for every 1 individual we're correct about, we're going to be completely incorrect for 2 others. And so since the 1980s or so, what we've seen is the establishment and the cross-validation of instruments that we call violence risk assessment tools. Now there's many of these that are out there today. To my knowledge, there's none that are specifically designed for military populations. This doesn't mean that we need to run out and immediately begin developing new tools, though. Simply what we need to do is start taking a look at the application, the reliability and the validity of these instruments when applied to military populations. And I think that that will be a very promising way forward.
And do you fear that there could be, that this could shift public perceptions of folks who've served in uniform and particularly in combat?
Sure, I do. I think that we would see something similar as what we see after school shooting tragedies, where all of a sudden it's there's the potential that what we'll see is a large stigmatization of individuals who have relatively prevalent risk factors. If we're dealing with school shootings, for example, if I say that someone is a loner, has a history of school problems, bad grades, and then I take a look at the entire population of individuals in school settings, we're going to see that these are very prevalent issues, meaning that we could be spending a huge amount of taxpayer dollars, and not only in terms of economic costs, but also in terms of social costs, because what we see from the peer-reviewed literature when it comes to aggressiveness and violence is that if you apply an intervention to an individual who does not truly need it, that it actually increases their risk of aggression. So by perhaps unfairly stigmatizing a large proportion of individuals who would not otherwise go on to be violent, it's possible that we could actually incidentally increase the risk of aggression on our bases.
Thanks very much for joining us.
Thank you so much, Michael.